Neither Dr. Bott nor I have any financial arrangements related to the content of this presentation, so nothing to disclose. We're going to talk today about components of a successful practice using a team-based approach, which is the gold standard recommendation for treating individuals with opiate use disorder. So we're going to talk about why it's important to use a team-based approach, the different components of the team, so and what their roles would be, particularly for implementing an office-based buprenorphine program. And then Dr. Bott will talk a little bit about some of the models of care that have been implemented, and we can problem solve or at least discuss some of the difficulties that can be presented administratively with building a team, because you do need to have some logistical and administrative support to enable the team to function the way it's intended to. So we'll talk about all of that today. So if we want to go on to the next slide. So we're going to address why it's important to use a team-based approach to really be able to support individuals with opiate use disorder as successfully as possible. Next slide, please. So there's a couple things to consider. We talk a lot about treatment teams, but it could be helpful to really think about what is the gold standard approach. And it really is what's called an integrated treatment team. So that's where you have not multiple service providers working separately with one patient, but working together truly as a team. So that means that there needs to be some space for this team to meet regularly, to be able to staff and to get on the same track, and some shared documentation practice. So that's what's called an integrated team. It's like multiple providers that actually work together. And this is a research proven model that has been shown to be effective with both individuals with serious mental illness as well as those with substance use disorder. And so it's particularly warranted with the population that we work with here in New Mexico that tends to fall in that dual category. So they have both co-occurring substance use and mental illness. It is considered the gold standard approach by almost every major regulatory body and research body to have this dedicated integrated treatment team, because what it does is it allows clients that have a whole myriad of needs to be able to receive combined treatment for their mental illness, their substance use, their psychosocial needs, from people who work together and can coordinate that care as well as convey a consistent message to the patient. We know that there's a lot of variables to be considering with working with this population. And so if you have a team that are on the same page in terms of what stage of recovery the patient is in, what treatments that are being recommended, what episodes of care they're actively engaged in or at least being recommended, you're going to be more successful at supporting that patient and moving through the continuum. There is a difference in the language that we use. So just to provide a little bit of nomenclature here, we kind of get these two terms confused a lot, multidisciplinary and interdisciplinary. And the gold standard falls into the category of what's called interdisciplinary. So multidisciplinary is just where we have lots of different people that are co-located and or treating the patient in sort of an ancillary. So I might be in a private practice, and I know that my patient is also seeing a therapist somewhere. They might also be doing peer support somewhere, but I'm not really working with those other providers. So we're technically part of a multidisciplinary team. We might even be in the same agency or the same building, and we're part of that multidisciplinary team, but we're not actually coordinating care together, meeting regularly, staffing regularly. Interdisciplinary is where we bring all of those perspectives together, and there's a shared treatment plan that is implemented by all members of that team. So that's where the shared documentation becomes really important, is that, you know, everyone that's working with the patient, whether they're in the same building or whether they're in separate buildings, we're sharing that treatment plan, we're meeting regularly. That's truly an interdisciplinary integrated team. Okay, next. So a couple concepts to consider when we're talking about treatment teams. One is, and this is something that we have to reiterate at ASAP all the time, because when we're talking about substance use disorder, we get really focused on abstinence. And it's important to keep in mind that recovery, the concept of recovery, what is going to help somebody maintain sobriety, or at least their recovery goals, even if sobriety isn't one of them, for the long term, has to be focused on the development of meaning and purpose in someone's life, not just symptom remission. So people can be sober, but they're not engaged in life. They don't have any major connection to loved ones, to work, to volunteering, to their community in a significant way. And so when a stressor comes along, which is unavoidable, they're highly vulnerable to relapse. And so one of the benefits to using a treatment team is that we can be looking at and attending to all of the components of what true recovery, which is about the development of actual meaning in a person's life. So not just stabilization, but actually integration into a full life. And what does that include? That means managing, my health concerns, my mental health concerns, family and interpersonal concerns, work or volunteer spirituality components. So making sure that we're attending to all of those domains for an individual and not just trying to get their symptoms under control. So a team can be much better suited to do that than a single provider alone. The other component of a team is that it's all the people that work with the patient, including the patient themselves. And that's crucial for success. If we're not regularly bringing the patient in on their treatment plan, having them contribute to that plan, and really giving them ownership of that plan, it's not going to be implemented, because at the end of the day, they're the ones that do the work. So that's why it's really important that, the patient is one of the prime members of the treatment team. Well, I lost my bullets. Looks like we might need to go back one, Dr. Bott. Yeah, one more. You go back. There we go. Okay. So yeah, if the patient doesn't have ownership of the plan, then they're much less likely to be able to work the plan and then get better. There needs to be infrastructure in place to promote the team and to allow the team to function as an integrated team. So that's why it's important to have buy-in from your administration or from your leadership, or even with yourself, if you're the one that is pushing for this team to be formed, to have the time and the space to be able to have team meetings and have that shared documentation. It's an expectation of the treatment team that they use some kind of a shared vehicle or multi-user vehicle, like a treatment plan, that can be shared amongst the providers, and that should be really the underpinning of all clinical encounters. So that's one location, either if it's an electronic chart or a paper chart, where everybody on that team can go and see that golden thread of what is being recommended for the patient, what they're doing, are they being successful, what barriers are they encountering, so that we're all on the same page together. And then when we meet as a team, we can add into that treatment plan to make sure that those notes are being updated every single time we talk about the patient. Okay, next. So now let's talk about what are the components of a team and go through each one of their roles. So teams have a specific structure that's recommended. Who is on the team is dependent on which type of team we're talking about. So that integrated treatment team is going to be your core team. That includes the client and all of the primary treating providers that are actively working with the client. The extended team are other service providers in other agencies. That could be like the dentist that you're trying to coordinate care with, because we need to talk about their medication in preparation for a dental procedure. That could be a peer support agency. That could be concerned significant others that are involved in that patient's care. So they're still part of the team. They're just not going to be at every single one of those meetings. They're going to be brought in sort of as needed for different pieces. So consider them as sort of that extended team versus the core team. And then what is the structure? Every team needs to have a dedicated lead or manager that really is responsible for at the end of the day, the buck stops here. I'm responsible for the treatment plan as a whole. So that could be any number of individuals on the team, but there needs to be one point person, or it's sort of diffusion of responsibility. There isn't follow up in regards to what needs to happen with that plan or the decisions that get made in the treatment team. The team also needs to have a dedicated coordinator. Sometimes in different models, they're called recovery coaches, but they're responsible for coordinating the team meetings and the communication, making sure that documents are intact and that information is sort of tracked and recorded in that, we're calling it the treatment plan, but the dedicated area that is for shared documentation. So you have somebody that's sort of running the meeting and that is responsible for signing off on the plan, and you have somebody who calls the meeting, make sure that everybody is there and that the information gets inputted into the plan, and then what next steps need to be followed, that communication gets sent to the other members of the team as needed. It's important on these teams that we don't get too rigid with roles. As we know, staffing changes and people are out sick or they're on vacation. So we all need to be pretty flexible. You need to have a sort of a defined role that's typical, like this is my role on the team, but I also need to understand what other people's role is on the team in case I need to jump in case I need to be able to do that particular thing to make sure that that meeting runs effectively and that those next steps are followed through on. So defined yet flexible. Next. So let's define each one of those areas. So the team lead or the program manager, this could really be any one of these areas. Ideally, it should be an independently licensed person. Probably this is not a role that we're necessarily going to give to like a peer support or a CSW or something, just because they need to be able to see all of the clinical components. So an independently licensed person can understand how those clinical pieces need to fit together for that big picture viewpoint. They need to be a person that does have at least consistent contact with the patient, so not somebody that never sees the patient. And they're responsible for really coordinating communication between team members and the patient as needed. So really sort of like the primary individual responsible for that patient's care. So they will definitely most likely have patient care functions. They might also be responsible for conducting any kind of education groups or support groups that are recommended as part of the program. And some of the models that are out there have been very successful at having nurses or nurse case managers be the team leads because they have a whole range of skills that they can provide. That independent license, especially with some specialty training, can be excellent at this particular role. So it doesn't have to be a doctor, it doesn't have to be a therapist necessarily. It could very much be a nurse that has frequent contact with that patient. Okay, next. The person that's responsible for kind of calling the meeting together and making sure that that documentation is put in appropriately. We could call them the recovery coach, or what we call at ASAP is the engagement specialist. They again could be a number of disciplines, but we've been really successful at using community health workers or community support workers, medical assistants or peer support specialists in this role. It would require a little bit of training to make sure that they know what their role is and what their responsibilities are, but they allow a lot of additional services to take place because they can play a major role in sort of the administrative piece. So making sure that even if they're not doing the prior auth, that the prior auth has been done, that the prescription monitoring has been checked, that prescriptions are current and accurate, or they can convene with the nurse lead and make sure that all of that information is there, that all of the clinical duties have taken place at the last encounter. This is particularly true with UAs. When you have a big program, you have a lot of patients, it can be easy to get off track with when a UA is due. And so they can really help with tracking that piece of it, making sure that certain screeners have been administered in a timely basis. They can also be very helpful at providing patient education, both at induction, but also as needed on basics of buprenorphine, harm reduction, pulling team members in when there's a concern or there's a particular complexity that's shown up, making sure that the patients have Narcan and that they've gone over relapse prevention, and that they have the kind of social supports that they need, that they're regularly checking in with them to see if they're following through on their counseling appointment or their case manager appointment. So kind of doing those phone check-ins or in-person check-ins with patients. They're really a vital person on the team. Next. The other thing, because we talked about that there's a lot of needs that patients have. So having a sort of a set list of referrals as part of that treatment plan, and then being able to say, does the patient need it or not, can really help, not with only meeting their needs now, but also with transition of care. So keeping in mind that we think about discharge from day one. And so it's really helpful to have, as part of the team discussion, what are the ancillary referrals that a patient might need? And so that could be any of our 12-step programs, traditional healers. They might need to go up a level of care or down a level of care. So they might need to do a period of time in an IOP or residential program, then come back to your program. Any crisis lines or additional assistance that's available in the community, where they might get a syringe exchange, different HIV or hepatitis testing services, and then food resources, housing resources, and then making sure that we're connecting them for employment and education resources. Because remember, it's about getting them well connected to life. That is the best thing that is going to prevent relapse in the future. Next. Psychiatric medical treatment. The therapist can play a big role. We know that it's not required for Suboxone, but it is very much recommended. That a lot of times these folks have comorbid mental health conditions. They have a lot of loss, a lot of trauma exposure, things that a therapist can be really helpful with supporting their opiate use disorder recovery. So therapists could really be, master's level or above, but somebody with psychotherapy training that also understands the complexities and components of buprenorphine, that they're aware of that. And the recommended interventions for this population would be anything that falls under the CBT umbrella, including relapse prevention and harm reduction. Motivational interviewing when appropriate, when they're in that stage of change. Contingency management is recommended for the opiate use disorder population, so if that's possible to implement. And then coordinating with 12-step programs or other peer support programs is also recommended. And if possible, using someone in-house, but if not, making sure that if they're part of that treatment team, that regular coordination of care and discussions are happening with the core team. Next. And then the pharmacist's role, they can be very helpful with making sure that naloxone is available, education is provided on the medications. They could be a part of your team for reaching out to community providers and providing community education. Also educating on chronic pain management practices, identifying, because they're looking at the different prescriptions that are coming through, identifying who might be at risk for possible overdose because of the other things that they're being prescribed. And so they can be kind of our first person to say, hey, we need to pay closer attention to this particular patient. Next. Having APNs or physician assistants on the team can be very helpful. We know now that they can prescribe. They could also be someone that is a lead for the team, but they can help manage the buprenorphine as well as the naltrexone. And they work very closely with physicians in what the physician's role would be. And of course, they're responsible for maintaining the physical health, the physical examination of the patient, making sure that they've done some sort of leveling of care evaluation to make sure that our patient is put in the right level of care by ASAM criteria, oftentimes providing the buprenorphine prescription and managing that, and then providing training and education to the rest of the team on the medications that the patient is being recommended. Next. And I think this is where you take over. Thanks, Dr. Bott.
Yes, hi. Thank you, Dr. Maley. Yes, I can take over for the last few slides. So this is sort of a, some of the models, the way they have utilized different members of the team in different capacities. And I think at the heart of it is really, part of it is leveraging resources, which can often be quite limited, right? And this really allows everyone to kind of really utilize their unique skill sets. And ultimately, as Dr. Maley really pointed out, if everyone is kind of working together, everyone has their roles that are defined yet flexible, and everyone is kind of contributing to and following the treatment plan, then we can really provide the best care to our patients. So this is really just sort of kind of a model, right? Part of it is also the training, right? And I think that's one of the things we really emphasize here in our Echo Clinic, is that we don't just want to speak with prescribers, right? We want to speak with people who are clinically involved in patient care, and we want to work together, right? So everyone needs to develop that skill set, develop that training, and in order to be able to step into the role. So this is just sort of a guidance, right? Aspects of buprenorphine management, treatment of opioid use disorders, and who should be trained within a clinic, within a treatment team. So prior authorizations, right, often carried out. I think over the years, certainly in New Mexico, this has gotten easier, but this is not the case in many other states still, right, where prior authorizations remain a big part or a big barrier to providing care. So it helps, right? We often utilize our medical assistants in this capacity at ASAP, at UNM ASAP, and that's worked well for us. But also front office or designated staff who can assist with billing, prior authorization, right? Prior notification, kind of very connected to that. So probably the same staff. Basic understanding of addiction. I think clinics work best if all staff, right, understand what substance use disorders are, what addictions are. So I think all staff, along with kind of how do you handle challenging behaviors, how do you set appropriate boundaries, right? All staff should really be part of that. Some other big ones, really, concerns will come up, kind of related to that boundary setting, related to challenging behavior. So those are kind of the basics of providing care, basics of working with individuals with substance use disorders. And I think it really helps to have all staff receive some training in it. Follow-up visit protocol, nurse or medical assistant, right? Phone script, where if a patient calls or if we're checking in with the patient, we want to make sure that we're using language that's not stigmatizing, we're giving message that's consistent, patient-centered. So I think anyone who's going to be answering phones. And finally, prescription monitoring program. I think at our clinic, we've utilized nursing staff as well as our medical assistants in that capacity. So that way, one person isn't doing everything, and people have received their appropriate training. Dr. Maley mentioned there are many models out there of team-based practice. Here I'm highlighting one that really utilized a team-based approach and showed some pretty good outcomes, which is the Massachusetts Collaborative Care Model. Again, at the heart of it was a team-based approach. You can sort of see the graphic image to the right, which really shows kind of all of these components that we talked about, right, coming together to help. And really, the idea grew out of the fact that there was a need for improving access to treatment, for individuals with opioid use disorders. So Massachusetts essentially implemented this model, and part of the model was training, something we also do here in New Mexico, and found that over a 3-year period, waivered physicians increased by almost 400%, 375%. They also found, more appropriately, that it increased patients receiving medication-assisted treatments, right? That's kind of the ultimate patient-level outcome. We want to improve access to care. And that was especially shown amongst religious ethnic minorities, right? Which is also important because disparities do exist in terms of who is able to receive treatment, who is not able to receive treatment. Just like Dr. Maley talked about, central to the Massachusetts Collaborative Care Model was the nurse care managers. So they were nurses who were specially trained to step into this role. And they really were central to the entire process. And they actually even did a cost analysis. And what they found was, and because again, a part of the consideration was that there was a shortage, right? There weren't that many waivered providers. So how can we use this model to really maximize what those providers are able to do, how many patients they're able to treat? And what they actually found was that in terms of cost effectiveness, if they paired one nurse care manager and one MA, they were actually able to treat about 125 patients, which is pretty phenomenal. And it was financially viable and sustainable. So how did it actually work? We talked a little bit about the training and who should receive what training. This is the patient flow, right, in this model. So say I'm a patient, I call up the clinic seeking treatment. So the nurse care manager does the initial screening assessment. So the nurse care manager sets up a time to speak with me, does the initial screening. What did that include? So it included a lot of things, right? Like including getting the history, the medical, social, psychiatric history, getting appropriate consents, treatment agreements, expectations, which is a part of it. What can you expect from us? What can we expect from you? As well as education on buprenorphine. What is it? What should you expect? Risks, benefits, as well as getting all the lab work, right? Hepatitis, liver function tests, HIV blood count, pregnancy tests when indicated, HIV testing with consent, as well as urine drug screening. So all of that was done at that initial assessment by the nurse care manager, right? With assistance by the MA, who would work very closely. The team, the entire OBOT standing for office-based opioid treatment team, would meet at a designated time and review these new intakes, right? So they would go over the initial screening assessment, right? And then if appropriate, if it seemed appropriate, they would be set up to talk to the medical provider, which in this case was an MD, who would carry out the physical examination, make sure the patient has opioid use disorder, and essentially that this should be prescribed. And then they would prescribe the medicine, right? And then a lot of the induction was actually done by a nurse care manager. So they would offer support, check in with the patient, see how things are going, make sure the patient successfully get onto buprenorphine. In some of the other newer models I've seen, particularly in some of our IHS and 638 tribally administered clinics, they've actually utilized peer support specialists very effectively in this role of helping patients to the buprenorphine induction. There unfortunately isn't enough literature on it, but I think that would really be a worthwhile thing to investigate and study, right? Because I think peer support specialists can be really helpful in this process, right, in that role. Patient support is provided again by the nurse care manager, who handles a lot of this, with the prescriber providing backup. And of course, again, the follow-up visits are done similarly, where the nurse care manager and the MA obtain a lot of the information. MD sort of checks in, make sure appropriate prescriptions are provided, make sure benefits exceed the risk. So that's kind of the general idea. And so what other role did the MD play, right? In addition to kind of doing the physical examination, diagnosing, prescribing, the other big part that the physician played was training, right? Kind of going back to this importance of training. So the prescribers would work with all staff, with other community prescribers, to build up capacity by doing buprenorphine waiver training, kind of doing addictions and buprenorphine 101 trainings for all staff, kind of including things like stigma, boundary setting, as well as offering ongoing training, shadowing opportunities, and clinical support to outlying community providers, clinics who may be interested in getting this going. So in some ways, similar to what we're doing, right? Except we're utilizing more of an echo audience. And they would also provide a tele-email backup. And they also made available their policies and procedure to any clinics that might be interested, right? Who can then adapt or modify them as they see fit. And then the education included a lot of the components we include in our education, including kind of basics, pharmacology, basics on buprenorphine, as well as kind of patient management concerns. So finally, just a note on clinic administrators, right? Because I think these things work when administration is supportive, understanding of the needs, and sees the need for providing this treatment, right? So the administration does need to be in a place to support the clinical team. There's a lot of barriers literature out there, examining barriers to buprenorphine prescribing. And one of the barriers that historically has emerged is lack of support from the administration, right? So I think this is very pertinent. So administration also needs to allow for regular meetings, right? This team has to meet for open communication, help arrange coverage if someone is going to be away. How do we handle it? Make sure appropriate staffing is available. Allow time ideally for trainings, continuing education, again, so that all staff can continue to build up their skills, their knowledge, and their ability to help these clients. Create clinic policies and guidelines. So what can we all do right now? So of course, to start with, be an advocate for your patients. I think that's something we all should be doing at all times. Help create an environment that's accepting, that is patient-centered, where our patients don't feel judged, right? Work within the community and beyond to combat stigma. Work with tribal, state, national leadership to enact policies that will benefit communities, right? Such as funding for treatment, drug take-back programs, education, youth engagement, naloxone distribution, right? And I think therein, again, the message I started with, which is that, policies matter, so please make sure you vote. And I'll end with that. And I think we have time